Welcome back, everyone. I'm Harshal, and I am absolutely thrilled to welcome you to Part 12 of our 15-part Interventional Radiology Coding Masterclass. Today, in this explainer, we're diving into something massive. We're going to demystify one of the most expansive and, honestly, most critical procedures in IR, abdominal aortography and lower extremity runoff studies. Now, if you've been with us through the masterclass, you know mastering vascular coding takes a seriously sharp eye for detail. Well, today, we're putting everything we've learned straight to the test. Let's get right into it. Here's our roadmap for this explainer. We'll start with a quick welcome to Part 12, then move right into defining abdominal runoff studies. After that, we're navigating the vascular highway, cracking the coding logic, and finally, we'll wrap up with a summary and a look at what's next. All right, Part 12, setting the stage. Let's do this. Moving right into defining abdominal runoff studies and looking at the clinical scope of it all. So I want you to imagine the human vascular system as this massive, high-speed interstate highway. When we talk about an abdominal runoff study, we're essentially mapping the entire southern route of that highway. It's comprehensive radiological imaging, and it starts at the abdominal aorta, literally the main trunk of our system, and extends all the way down through the pelvis, continuing into the arteries of both lower extremities right down to the feet. So yeah, it is a huge, multi-level snapshot of the body's plumbing. And looking at this sprawling vascular network, you can really see just how intricate these branches get as they extend outward. It's almost like a giant puzzle. Physicians absolutely rely on this massive map to pinpoint peripheral vascular disease, locate severe blockages, and meticulously plan revascularization treatments. Without this map, navigating those interventions would be pretty much impossible. Okay, let's switch gears and look at navigating the vascular highway and the actual procedural execution. These procedures really are miracles of modern medicine, mostly because they utilize these minimally invasive percutaneous approaches. Instead of making massive surgical incisions, the physician relies on specialized, highly engineered tools, stuff like catheters and guide wires. Using real-time imaging guidance like ultrasound or fluoroscopy, these incredibly thin tubes are just carefully, smoothly navigated right through the vascular system. Let's actually walk through the physical journey of the procedure chronologically. Usually, the physician kicks things off by accessing the common femoral artery in the groin, safely threading a guide wire through a percutaneous puncture. Next up, they place a non-selective catheter, advancing it all the way upward into the abdominal aorta. And finally, contrast dye is administered through a power injector. This literally illuminates the aorta and that entire lower extremity arterial tree on the radiological imaging. It's just amazing to see. As that contrast flows south, it lights up some key anatomical landmarks that you, as a coder, absolutely must recognize. We're talking about the visceral arteries, which branch off to the organs, the iliac arteries in the pelvis, the femoral arteries down in the thigh, and the tibial arteries in the lower leg. Knowing these junctions, totally non-negotiable for accurate coding. You've got to know the local roads. All right, time for cracking the coding logic and translating all this clinical work onto paper. Here is the golden rule of interventional radiology coding. You ready? You absolutely must distinguish between two totally distinct elements of the procedure. On one hand, you've got catheter placement. This is the physical, mechanical movement, the final positioning of the tube within the vascular family. But on the other hand, you have supervision and interpretation, or SNI. That represents the radiological imaging, the guidance, and the actual diagnostic evaluation of the vessels using the contrast dye. You have to capture both things, the physical movement and the imaging. Let's test this out with a real-world clinical mystery directly from our source material. Picture this. You're reading an operative report. The physician accesses the right femoral artery. They advance the catheter into the abdominal aorta, inject contrast and image it. Okay, then they advance the catheter into the left common iliac artery and take images down to the foot. Finally, they advance the catheter even further into the left superficial femoral artery to evaluate the tibial level. So the big question, how many catheter placement codes do you report for that entire journey? Well, here is your definitive coding rationale. You code only the left superficial femoral artery for the placement. Why? Because the rules of selective catheterization dictate that the final, most selective placement automatically encompasses all the lesser lower-order selections made along the way within that specific vascular family. You don't code every single stop on the highway, right? You only code the final destination. And I just want to take a quick second to remind you why mastering these specific coding nuances is so crucial. Actually, it's not just about compliance, it's way bigger than that. Accurate coding reflects the true complexity of the life-saving diagnostic and therapeutic work being done by these physicians. Properly coding a comprehensive runoff study ensures that the incredibly intricate work of identifying dangerous vascular blockages and guiding these critical cardiovascular interventions is fully 100% accurately represented.
Which brings us to our summary and what's next. Looking at
So, we've cracked the logic of coding single physician placements. But hey, our journey through the vessels isn't quite over yet. I want to leave you with a bit of a provocative question to chew on before our next session. What happens to our S&I coding rules when two entirely different physicians collaborate? Say, one handles the surgical physical catheter placement, and the other entirely handles the radiological imaging and interpretation. It gets tricky, for sure. We are going to unravel that whole complex scenario in Part 13, where we dive super deep into supervision and interpretation and dual physician roles. Until then, review your vascular families, keep practicing those hierarchical coding rules, and thank you for watching, and keep learning with Decode Healthcare with Harshal.